The next speaker will be Professor Muhammad Abdul Ghani. He will present case studies on the treatment of type 2 diabetes.
Okay, thank you. Now we'll run. So everyone will go tomorrow morning to his office, and a patient that will show up is 45 years old, female, BMI 36, type 2 diabetes for 6 years. Their story is that when she was diagnosed, she was started in Genomed. Then after 2 years, A1C increased, glycoside was added. Because of poor glycemic control, 1 year ago, the glycoside was stopped, the DPP-4 was stopped, metformin was continued, and she started on lactose 36 units before breakfast, and now she shows tomorrow with fasting glucose 2221, A1C 9.8. So what do? You intensify glargine, you switch glargine to Novomix because glargine is not working, you add glargine and metformin 5-glitazone, or you restore DPP-4 and glycoside that should not have been stopped. Which one you pick? Two. Which is which? The Novomix. Three. So all fail. That's the last thing I would do. Because that's definitely, after the 40 studies, that's the worst insulin regimen that you can give. Pre-mixed insulin. Three is reasonable. One is also reasonable because obviously that 36 units of insulin is not, glargine is not sufficient because the fasting glucose is 221. And we just learned today that fasting glucose is high because during the night the patient, the liver is producing glucose, and the way to control it is by intensifying glargine. So definitely 2 and 4 are wrong, absolutely wrong. 1 is reasonable, I would say 3 is also reasonable. But in this particular case, the treating physician decided to escalate the insulin dose. He added 4 units of glargine each week while titrating the fasting plasma glucose. And then after 6 months, the patient is coming back. She is receiving 126 units of glargine, which is a humongous dose, more than 1 unit per kilo. The patient has gained 16 kilos over the 6 months. And she is experiencing some hypoglycemic events about once a week. By the way, this is a real case from Qatar. I connected with Dr. Khalid Hussein here. And her fasting was 148, and A1C is 8.1. So, what you do now? Keep increasing glargine to get fasting 110. Switch to Novomix. Add GLP-1 to cause weight loss. 4. Or measure C-peptide. 3. Add GLP-1. Okay. So here, there's a point I wanted to make. If you are a cardiologist and somebody comes with you with ischemic heart disease or heart failure or whatever, you start. What is the first thing you do on the patient? You examine. He has heart failure. He has diuretics. See, when I was in medical school, this is how the teacher, I remember, I was presenting a case, what you do, everyone was start throwing drugs. He says, if you do that in exam, that's the guarantee way to fail the exam. If a patient with cardiac disease comes to you, the first thing you have to do echo to see what kind of heart you have, what kind of heart you are treating. Now, when we are treating diabetes, what are we treating? Should I return to what just a minute ago said? We are treating the beta cell. So when you are treating the beta cell, you definitely want to know what kind of beta cell you are treating. So in this case, we measured C-peptide. And so we measured the C-peptide before we decided what to do, because that will guide us what to do. And in this particular case, the C-peptide was 4.6 nanogram per ml, where the upper limit of the acid there is 2 nanogram per ml. So does this change anything the way you want to manage the patient?
Add DPP-4.
Add DPP-4 inhibitor. So what does this C-peptide 4.6 tells you? That the patient has endogenous, she's full of insulin, almost full of insulin to the ears, right? Endogenously. We are adding 126 units of insulin exogenously, and still the A1C is 8.
Resistance.
This is severe insulin resistance, very severe case of insulin resistance. So by measuring the C-peptide, now we know what's happening in the body of this patient. So if this patient is severely insulin resistant, what the DPP-4 is going to do? Or SEO. So in this case, we added pioglitazone, and the treating physician added 45 milligram of pioglitazone. And after 5 weeks, the patient is calling urgently the doctor. She has gained 9.5 kilos, suffering from ankle edema and multiple hypoglycemic events. And the glucose was even dropping up to the 50s. So then, the doctor asked her to come to the clinic, and what he should do: stop pioglitazone, because a lot of troubles, weight gain, hypoglycemia. Decrease the insulin dose. Decrease the insulin and decrease the pioglitazone. Exactly. Why decrease the insulin?
Because she's already full of insulin. The requirements are less.
But why because it's hypoglycemia. But why decreasing the pioglitazone dose?
Edema.
Exactly, because there's extreme response in terms of adverse events in order to reduce the adverse events.
You start 45 milligrams right away.
That's what the physician did.
What are you?
No, okay, we'll come. Wait the story to the end.
No, I want to know.
Well, we'll come. Don't worry, I'm not going to run out of that. But just we'll go one at a time. Okay, so the patient came. She had +4 pitting edema in both legs. Physician reduced the pioglitazone to 15 and the glargine to 40. And then asked the patient to monitor the fasting glucose and to come back. And after 2 weeks, the patient came back. She had lost 6 kilos, still has pitting edema +2 in both legs, and her fasting now is still in the low range, 65 to 75. So, you stop pioglitazone, keep decreasing glargine. Stop pioglitazone. What will happen if you stop pioglitazone? You go exactly where you started. Keep decreasing glargine. Yes. And stop pioglitazone, decrease glargine dose. We said we don't stop pioglitazone, because if you stop the pioglitazone, we go back where we started. And that's what the physician did. He kept down titrating the insulin, the glargine dose, and then decided to reduce the insulin dose and maintain the 15 milligram pioglitazone. And after 2 months, the patient is lost additional 5 kilos. I want to go back here to the fact that after 2 weeks, the patient has lost 6 kilos. In order to lose 6 kilos in 2 weeks,
Fluids.
this is fluid, exactly. So most of the weight gain by pioglitazone in this patient was actually water. Water retention was not fat, and therefore, once you stop or reduce the drug, you're going to lose the weight very quickly. And after 2 months, the patient has lost additional 5 kilos. She now is on 16 units of glargine, the fasting level around 100, and the A1C is 6.4, and no hypoglycemia. But still, edema +1. So, she's complaining about the edema. So you stop the pioglitazone, you anti-zyme, anti-tactone, or furosemide. So the only thing we need to take care of here is about the edema. So one option is to further decrease the pioglitazone, because you saw that the adverse events is dose dependent. You decrease the pioglitazone, you reduce the adverse events. Although now she's on 15 milligram daily, but you can go to 15 milligram every other day. And that will further reduce the side effects, but that also will reduce the efficacy. In this case, we added aldactone. That's what specifically causes the loss of sodium in the distal tract. This is how the sodium retention is happening in the kidney. So the specific diuretics to treat the edema or the water retention from pioglitazone is adding aldactone. And by the way, I can remember 2 patients who were on once weekly 15 milligram pioglitazone that was sufficient to sensitize them for lowering the glucose without the adverse events of water retention and weight gain. So we didn't stop the pioglitazone, we added the aldactone, and then the patient came later happy, well controlled, A1C 6.2, no hypoglycemia, and the ankle edema disappeared. Now, just a question, if we now will repeat the A1C, the C-peptide measurement. Remember, it was 4.6 at the beginning. If we now, after it's well controlled now, we repeat that C-peptide measurement. What the result would be?
Decreased 1.5 to 2.
4. Exactly. Decreased markedly. Why the A1C, the C-peptide decreased markedly? It's because of two things. One is because the fasting glucose went down, but more importantly also because we improved the insulin sensitivity, so reduced the demand for insulin. So if you want to learn a lesson, from this is that the use of pioglitazone is never like metformin. You give one dose, either it works or it doesn't work. If it works, good. If it doesn't work, then you throw it away. You need to titrate the pioglitazone exactly as you are titrating the patient. This is, I just want to show you data. I think you saw that. So the treating insulin resistance in type 2 diabetes is very important in order to achieve the durable reduction in A1C. And the severity of insulin resistance, it's difficult in severe insulin resistant individuals. It's very difficult to achieve glycemic control without treating, without addressing the insulin resistance. And you saw in this patient, as an example, despite 26 units of insulin, the patient is still poorly controlled. And the important lesson here is that pioglitazone dose should be titrated. It's not single dose that fits everybody. You should titrate, you should tailor the dose to each patient based on the response in terms of reduction in the A1C and in terms of adverse events, which are the major adverse events, the weight gain and the edema.
And echo was done or not?
Say again?
Echo cardiography was done for him?
No, we didn't do echo for this. I just measured set the echo as an example for cardiologists. The C-peptide here is our echo for the pancreas. Now, the other thing I want to tell you is don't be scared if the pioglitazone has a severe adverse events in terms of weight gain and water retention. Because the more severe the adverse events are, that's an indication for the efficacy of the drug in this patient. And you should manage that by lowering. That means that in this particular patient, the drug is very effective, and you should manage that by lowering the dose because the adverse events are dose dependent. And the other thing is the weight gain, which is fat weight gain, is the adverse event that you are concerned about. Just combine it with other medications that causes the weight loss, which are GLP-1 receptor agonists or SGLT2 inhibitors. This is, I want to show you that, then you saw that to the front, so that pioglitazone, not metformin, is the true insulin sensitizer. This is with people before and after metformin. When you prevented the weight loss with metformin, insulin sensitivity measured the claim is exactly the same before and after. Metformin doesn't improve insulin sensitivity. Okay. Second patient, 65 years old, male, 76 kilos, BMI 27.3, hypertension treated with ACE and amlodipine, has a mild CVA, 2 years ago, blood pressure is well controlled, LDL cholesterol is okay. In the routine labs, he has fasting glucose 192 and A1C is 8.7. So what would you start him? So then the neurologist is calling you and telling you he's diabetic. So what would you suggest to start this patient on? Metformin plus lifestyle intervention. That's what the recommendation is to onset diabetes. Start him on pioglitazone. Pioglitazone plus metformin. We'll measure C-peptide.
4.
3. Okay. 4. I won't object to that because in my doing practice on IC patients, I like to see the C-peptide for every patient, diabetic patients that I'm treating. By the way, I like also to do not the fasting, but also stimulate. Ask the patients to come fasted with his breakfast, take in a glucose C-peptide in the fasting state, ask him to eat the breakfast, and then take it 2 hours after. That's not an objection, but if you want to treat just without reading, without doing the C-peptide, widely, the recommendation, the guidelines are 1.
But GLP-1 is better for him, or HGP, or sodium glucose.
The guidelines tell you this is not
lifestyle change with
That's what I'm saying. The guidelines say it's advanced diabetes, you should start metformin with lifestyle.
She has already cerebrovascular disease.
Right, because this patient has CBA. And we already saw yesterday, the IRIS study, people with CBA, there's a 24% reduction in 3-point MACE. Heart attack, stroke, or death. If you want your patient to have high risk of cardiovascular outcome, you should not put him on pioglitazone. So if you can start on him on pioglitazone, but if and 3 also is another option, you can start in combination of metformin plus pioglitazone, probably because everyone's starting A1C is 8.7, I would start him on combination because it's more likely to bring the A1C into target. So the physician started the metformin, 2 grams plus pioglitazone 30 milligram. After 3 months, the fasting glucose is fine, the A1C is 6.1. However, the patient gained 6 kilos and no petit edema, but he's complaining about the weight gain. So what you do? Because you complain about weight gain, you stop pioglitazone. You reduce the pioglitazone, replace metformin. Excellent. So I see that you were listening in the lecture. So not sitting there.
So if he has CVA, if he has history of stroke,
Right.
you would give SGLT2
Yes, I would give SGLT2.
even if he has a history of stroke.
Yes,
Yes.
because SGLT2 will reduce his blood pressure, although the benefit on the reduction of stroke was not as big as in the heart, but definitely in the EMPA-REG, yes, I know in the EMPA-REG there was about non-significant increase, but that was not reproduced in the other 3 studies, in the DECLARE, in the CANVAS, and in the Credence. The other thing is what they did in the EMPA-REG, they took people also after 90 days from discontinuing the drug. And when they did the analysis, just by the time they could discontinue the drug, this is where the excess incidence of stroke happened. 3 months after they discontinued the drug. Could be coincidence, it could be rebound for the blood pressure because of stopping the drug. Could be just by chance, but that's what they did. But the fact is that in the other 3 studies, large studies with the other SGLT2, there was no insignificant increase. Although the benefit, and that is surprising, I always ask me, because when you reduce blood pressure from all blood pressure studies, the first thing you get greater reduction in stroke. But despite these drugs lower the blood pressure, they don't get the benefit expected from lowering the stroke as much as they're improving the cardiac outcome. Why is that? Nobody knows, but at least it's not detrimental or it's not harmful to add it to a patient who has stroke or with a history of stroke. Okay, so this is what Dr. DeFrazzo told you yesterday from the proactive study, is that the weight gain with pioglitazone should not scare you, because this is the risk of death. In the proactive study, the hazard ratio on the y-axis and the x-axis you see the BMI. The higher the BMI, the lower the hazard ratio to die. So when you treat with pioglitazone, the greater the weight gain, the less likely, the more protected against death. And this is in the also Captain Micro. You see that the lower the BMI, the lower the gain with pioglitazone, the higher risk of death, and the higher the BMI, the lower risk of death. So in weight gain per se, with pioglitazone shouldn't scare you. You can manage it by changing the dose of the drug, or if it's weight gain, fat weight gain, not fluid retention, you can combine it with medications that cause weight loss. Okay, so that's what I just told you. Okay, third patient. 52 years old, male, BMI 31.4, hypertension, ischemic heart disease, has type 2 diabetes for 2 years, which started following an acute MI. He receives ACE, statin, aspirin, metformin, glargine 58 units every morning. Blood pressure is 142/87, LDL cholesterol 92, A1C 7.8, eGFR 76, and he has macroalbuminuria. What do you think the target for treatment for this patient? Where the A1C should be?
4.
4, 3, 1.
لازم
So everybody.
hypertension.
Okay. So the guideline says that there should be 7 or below, right? 2 to 4, or should be between 7 and 8.
4. 4, yes, has a lot.
That's excellent because oftentimes, because this guy has ischemic heart disease, he's after MI, this is how his diabetes started. And oftentimes, physicians scared when you have ischemic heart disease that they think that the A1C should be loose. You should lose the A1C. If you do that, you put your patient at risk. Now I'll ask you, yes, he has microalbuminuria. His eGFR is 76, he has 2 years of diabetes. What do you think about this eGFR? He already has neuropathy. Okay, so then we have to work hard in terms of glycemic control in order to protect the kidney. So that's another reason why we should bring the A1C as low as possible, as long as it's safe and doesn't increase the risk of hypoglycemia. That's the point, and that's after the ACCORD study, people start to shake a little bit from lowering the A1C, but the fact is people are misinterpreting the ACCORD study because the mortality was higher in the intensive arm, and then people start to be scared. But when we analyze the data, you look at the intensive arm, this is the A1C and this is the risk of death, you can see that the higher the A1C, the greater the risk of death. So it's not the intensive treatment that increased the mortality, but something else. What is this something else? This is the something else. They plotted here the risk of mortality versus the decrease in the A1C during the first year. The greater the decrease in the A1C the first year, the lower the mortality. Who are the people who died? People who, despite intensifying therapy, did not reduce the A1C. Let's take, for the sake of argument, most of the intensification was with insulin. But it's not the insulin that caused this. But for the sake of argument, let's say they intensified only with insulin. So you add insulin to somebody, and then his A1C is not moving, it's not decreasing. What does that tell you?
Has already reached sufficient beta cell.
Beta cell has nothing to do with this. You add insulin. Insulin is supposed to lower the glucose regardless what your beta cell is doing. And that means you are severely insulin resistant. We go back to case 1. Right? You give insulin, and the A1C is not decreasing. Those are the guys who died. So from this, it tells me that the guys that they had the highest mortality in the ACCORD, in the intensive arm, those people who were insulin resistant, and despite intensifying the therapy, they did not lower the A1C. That's my conclusion. Whether that's true or not, I don't know. But the point is that lowering the A1C per se, that was not the cause of death. So this is why in this patient, you shouldn't scare and lowering the A1C as long as you do it safely. The question is, how do you achieve that in this patient? So you add sulfonylurea. Remember, he was taking a glargine 58 units and metformin, and his A1C is 7.8. So how do you intensify? 4. Why 4? Let's go back to this patient. Yes. So he has many causes to add this SGLT2 inhibitor. One, he has ischemic heart disease, so it's diabetic and post-MI. Second, he has nephropathy. Thirdly, he will lose weight, exactly. And the last thing is his blood pressure, although he has a treatment of blood pressure, but his blood pressure is 142/87, so it's going to lower also further his blood pressure. So empagliflozin 25 milligram was added to metformin and insulin in this patient, and his fasting glucose after 2 weeks is shown here. His A1C is 7.3. So this is his fasting glucose, sometimes low, sometimes high. What's happening here? Must reduce the insulin. What's happening here? He's doing hypoglycemia. Sometimes it's strong enough to get a rebound, as emoji to rebound hyperglycemia. Sometimes it remains low. That means he is in hypoglycemia. And the answer is to decrease his insulin dose. Okay. So the last case is 65 years old, to show that not everything is simple. History of type 2 diabetes has for 9 years. in history of 2 MIs, is BMI 34.3, blood pressure 122/82, pulse 61, and A1C 7.8. His creatinine is 1.6, eGFR 61. And his left ventricular ejection fraction is 41, because he's after 2 MIs. And he has macro albuminuria. He received metformin, insulin Novomex, aspirin, ramipril, carvedilol, and furosemide. So this patient is optimally controlled. Shouldn't she need to be optimized? Okay, what are the problems? Okay, so first of all, this patient has ischemic heart disease and heart failure, right?
Nephropathic.
And he has nephropathy. He can benefit from the SGLT2, but is it, let's say if we add the SGLT2 to this patient. We can, of course.
What's
the problem?
We must decrease the ramipril dose.
Okay, so one is that the eGFR is 1.6, so he may increase the creatinine because that's what's happening. Second major problem is blood pressure is 152. If we want to decrease, to give a SGLT2 who's going to lower the blood pressure, that might cause a problem in terms of tolerance to the blood pressure. So therefore, we need to adjust the other medications. So the lowering the blood pressure is a problem. His A1C is low, therefore he's at risk of hypoglycemia. So this patient has a meal tolerance test, and his fasting C-peptide was 2.1, and his 2-hour C-peptide was 5.6. Meaning? Now, what does it mean that his fasting is 2.1 and his 2 hours 5.6? That his pancreas is still working, right? So in the diabetic patient, if he's fasting 2.1, who doesn't have residual beta cell function, you will see after 2 hours it will be 3.5. So still has pancreas that can work, and you can use that pancreas. What does that tell us about the treatment? He's receiving decreased insulin. So that tells us that we can manage this patient with medications, probably oral medications, without the need of insulin, right? So this is very important information about how to manage, and this is an example on how I'm telling you that this is our echo to the pancreas. We need to know what's happening to the pancreas in diabetic patients because that's what we are treating. So we discussed that. So what happens in these patients, we lowered the insulin, we added the SGLT2 inhibitors and GLP-1 receptor agonist, and we were able to wean him off insulin and maintain good glycemic control and get the benefits, all the benefits from the SGLT2 and GLP-1 in terms of cardiovascular and in terms of renal effects. And that was the last patient.
Thank you, Dr. Abdul.